everybody. Thank you for joining us today for our town hall. My name is Julia Dobbins, and I work for the National Healthcare for the Homeless Council. I just start by acknowledging the heaviness of the reality that we are all living in right now. I know the consequences of this virus are probably weighing heavy on you, your colleagues, your organizations, your communities. And I know that for a lot of folks, just keeping your heads above water right now is difficult. So I hope that there is some comfort in the solidarity of this community. We are keenly aware of the vulnerability of our clients, and that is even without a global pandemic. So I can imagine that in the face of something like this, the urgency of your work might feel overwhelming right now. So I just want to say that we see you, we are with you, and we're really glad that you are joining us today as we talk about the role of medical respite care in our response to COVID-19. So if this is your first time joining us for the town hall, just to give you a sense of what the purpose of this town hall is we really want to hear from each other about what you're trying, what's working, what's absolutely not working in your communities, what challenges you're facing, what strategies or ideas you're putting into place to meet those challenges. You know, we're hearing that the response to COVID is really community specific, and that is true as well for the development and delivery of medical respite services. So we really want to hear from you today, so I encourage you to use the chat box. Some of you are already using it, which is great. Feel free to ask questions, to, hello, Christina, to ask questions, to answer questions, to share stories, to share lessons learned. We're really interested to hear what's happening on the ground for your community. I believe that everybody here is familiar with medical respite care, but or recuperative care, as we also call it. We use these terms interchangeably because they describe the same service. But just to make sure we're all on the same page, how we're defining medical respite care, it is short-term care for people who are homeless, who are too ill or frail to recover from an illness or an injury on the street, but who are not sick enough to warrant hospital-level care. So the question then becomes, what does medical respite look like in the face of COVID-19? And that is what we're going to spend the next hour chatting about. I am so grateful and excited to have our presenters here with us today. First, we have Donna Biederman, who's joining us from Durham, North Carolina. Additionally, she has some birds in her house who might be joining us as well, if you hear a bird. And then we also have Melissa Brown and Leslie Enzian joining us from Edward Thomas House in Seattle, Washington. Thank you guys so much for being here. We really appreciate it. And with that, I'm going to stop talking and turn it over to our Seattle team. Take it away, Leslie. Leslie, I think you're on mute.
Can you hear me? Yeah, great. Thank you, Julia. Welcome, everybody. I'm glad that we're able to connect today just to talk about lessons learned and discuss remaining questions. And I'm very interested to hear solutions that you have found in your community that we all might be able to draw upon. Because COVID-19 hit our area in Seattle first, I think that we might be a little further along in planning than some other areas that had a later onset of the outbreak. And I hope that some of our practices and protocols might be of use to you. You will have access to a large number of documents that detail our protocols that perhaps will be of assistance to you. I just wanted to provide brief context of our program. Edward Thomas House is a medical respite program in Seattle, and we're a 34-bed freestanding respite unit. Prior to moving into our current facility, we were a shelter-based respite program for 16 years, so I think we have quite a number of insights into the shelter models. We are a harm reduction program, and many of our patients are actively using and are able to remain in care as long as they're behaviorally appropriate and participating in their medical care. We manage a high acuity of patients, including the delivery of IV antibiotics, and we also have a high behavioral acuity and have quite robust mental health staffing to support that. Our program is run and staffed by our county hospital employees, and we're fortunate to be under the umbrella of the University of Washington School of Medicine and to have the connection with our county hospital because we get a tremendous amount of support from the infection control services, the environmental services for sanitation, and access to all of the University of Washington protocols that have been of great help to us. I also am a primary care internist at our hospitals, one of our hospitals' community clinics downtown, and we'll just say that in our area, COVID was late in manifesting in the homeless population, and we have been testing a number of shelters after identifying single cases in the shelters and are seeing increasing numbers of cases. We face a number of challenges, as I'm sure all of us have, in trying to manage the onset of illness in our homeless population. And our public health department has worked very hard to set up a number of shelters for COVID-positive patients. Early on, the process was very cumbersome. If we needed to get a patient into the shelters, we often have very long wait times, and the telephone line access was mixed with all of the community people just calling in with their own concerns. So there were a lot of logistics that needed to be refined around that. We also have struggled with getting a number of our patients in, and it had been unclear as to what the eligibility criteria were and who was making the decisions and why some of our patients had been declined. It became apparent that there was some screening happening around substance use disorders and also criminal history, and we've been working to navigate those issues. In our area, there appeared to be quite a lack of foresight in preparing for managing substance use disorders in the midst of this outbreak, and how to manage patients in isolation who were on methadone maintenance, how to manage patients who needed to be in quarantine and were in withdrawal and had cravings and difficulty staying in quarantine, and then just managing substance use disorder behaviors. And because we have had so much experience with that in our Respite program, we have been able to lend a lot of support to our bigger community, our larger community, in preparing for keeping substance use disorder patients engaged in care. Also, with the rapidity of the setup of these COVID shelters, they have been often staffed by personnel who don't have training in trauma-informed care or harm reduction, and so we have looked for ways that we can support those staff in optimally managing our patients. We have struggled quite a bit about should Respite admit COVID-positive patients, should Respite keep current Respite patients who become positive. We have struggled with a lot of staff reservations about doing that, and it has been a challenge that, as I'm sure for you all, that the recommendations about personal protective equipment and practices have been changing just at an astronomical rate that can be overwhelming. So the downside to having COVID in Respite, one that we have immunocompromised patients. Our program has a number of patients on chemotherapy with advanced HIV. And aside from that, we have patients with other high-risk medical morbidities. And so the decision to accept COVID patients on the unit has significant and serious ramifications. In addition to that, a program might end up with a mixed population of, if you don't turn all your beds into COVID positive or keep everybody out, you have to manage appropriately a mixed population of having some patients positive and some that are negative. And then what I already mentioned is there are significant challenges for patients that have underlying mental health or substance use disorders in their ability to comply with recommended quarantine. In our program, we early on decided to set aside 2 respite rooms as isolation rooms. Each room has 3 beds. And we also have a plan, although we have not yet needed to enact it, of using our community space as a COVID lounge that would be able to accommodate patients who are test pending. So the pros to having COVID patients in respite are that the patients in respite by and large have medical needs that cannot be met by the new COVID shelters that have been put in place. We have staff that are tremendously experienced in managing substance use disorder, that are trained in trauma-informed care, and we have a lot of processes in place to be able to manage acute medical issues. And then I also feel that from, at least in our community, I feel like respite has a responsibility to contribute to the response, and that might happen in different ways. So it might be that a program does not take any COVID patients, but you just maximize access for non-COVID patients so that you open up hospital beds for the acutely ill COVID patients. Or it could be that you take some number of COVID patients so that you increase access for shelter COVID beds and increase access for COVID beds in the hospital. So there are different ways that can play out. You will have access to our COVID protocols, and in terms of our referrals, we have been screening all referrals for symptomatology, and if they were symptomatic, requiring testing prior to admission. We have transitioned now into testing all new admissions if they don't have a recent negative test. Our protocols really focus on maximizing patient success in isolation, and includes information about what if the patient can stay in their room and how to manage patients who are struggling with substance use issues. Our protocols very much limit staff interactions, and we minimize vital signs. We're not doing them on a daily basis. They're very much symptom provoked, and changing dressings to multi-day dressings in order to limit the potential for exposure to our staff, and yet provide some degree of safe medical monitoring. And then our downtown program, which we are connected with, has partly in part because of the difficulty in getting our patients into the public health shelters, we ended up developing our own COVID shelter that is a block away from it. It has 40 beds. This way quickly is much less formal than respite, is a low barrier, and is that way out of necessity, because the formality and intensity really of our respite program screening really would not be appropriate with limited access. The facility has 4 spaces, one for COVID pending men, one for COVID pending women, and then men's and women's COVID positive rooms. And then we have what we call a cold room that is only for staff, and then we have warm spaces that are a mixture of staff and patient areas. The staffing, we have 4 hours of nursing care per day, advocated for a lot more than that. We have medical assistants in the daytime. There are 2 EMTs on at night, and then we have a physician who rounds 2 hours a day and who is on call through the day and the night. The protocols are very intentionally set up such that any staff could do an intake on a patient. The EMT could do an intake, the MAs can do an intake. They're very pared down from our more formal respite intake procedures and eligibility criteria. You will have access to details on the protocols that are in place for substance use management. That I think warrants a little bit of conversation. So we really initiated a conversation about managing methadone maintenance for COVID patients, and and really led the way in establishing protocols and arranged for the methadone programs to do on-site delivery of methadone and set up all the documentation formally with chain of custody. And the DEA has very much backed off on restrictions around management of scheduled medications that allow these practices. We also are working in Harborview Hall to manage acute alcohol withdrawal using Librium tapers that are specified and you'll have access to, also using mirtazapine and Librium for patients in methamphetamine withdrawal. Alcohol withdrawal is particularly challenging in that many of the symptoms of alcohol withdrawal are the same as you would see in an acutely ill COVID patient. And so the standard parameters that we use to determine how serious it is don't apply. So it takes some additional forethought and planning. And with that, I'll turn it over to Melissa. Thanks for your time.
Hi, everybody. I thought I would focus on patient and staff support in the next couple of slides. Patient support, as you might imagine, our patients are really frightened about this, and there's a variety of understanding of what's happening with the virus and how it's transmitted. So all of our patients in the medical risk that we have set up, all of our patients see a nurse at least once a day. And during their daily nursing visits, our nurses are screening for symptoms and then providing education and guidance regarding social distancing and hygiene. If somebody screens in and has any sort of symptoms, that's when we move them into one of our isolation rooms, and we swab the patient in the isolation room and then keep them there while we're waiting for the test results to come back. Initially, the results were taking about 36 hours, which is a long time to keep someone in isolation who then ends up being negative. But now the test results for us are around 4 to 5 hour return, so that's really great. We have cleaning protocols in our clinic and throughout our entire facility. During the day, we are, well actually throughout 24 hours a day, we are bleaching all of the high-touch areas throughout the entire facility, and in the clinic, exam rooms every time, of course, per usual, and more bleaching in the clinics than usual. We have signs at the front and gel available for patients throughout the entirety of the facility, but a reminder, especially when you leave, gel out, when you come back in, gel in, and it's sitting right next to the entrance so that folks have that opportunity to do that. Throughout the facility and even outside, today we have some that we're putting outside in the areas where people are smoking that are public areas. We're placing signage with reminders about hygiene and social distancing. We made a big effort to try to explain what our governor's stay home, stay healthy order means for our patients. And we have signs outside each patient room. We have a big mental health team that, in addition to our nursing team working with patients on this, are providing lots of education and one-on-one support for our patients and reminders around social distancing. We've actually changed up our community room area so that there's not a sofa where 2 or 3 people can sit next to each other. We've tried to move things within the facility to encourage social distancing. We've made some accommodations in our usual guidelines, like, for example, around food. Previously, we encouraged patients to eat in the community room in the dining area because we don't want there to have rotting food in patient rooms. Now we're encouraging patients to feel free to take their food back to the room and be able to social distance around mealtime. Also, our patients are, as much as possible, doing telehealth with their providers. Currently, they're using just a telephone to do that, but we have just received the equipment for webcams and microphones for our patients to be able to have 2 different stations in a private area where they'll be able to telehealth with their providers so that it cuts down on the amount of time they're leaving the respite facility and entering into our clinic space throughout the county. As far as staff support, we've really focused on transparent communications. We've been trying to package all of the information to our staff in 1 email a day instead of multiple. There's so much information coming out that it can be really overwhelming. We have frequent huddles and report during shift change, and we use that opportunity to have an open forum to address any questions or concerns that might come up. We incorporate our staff in all of our planning and incorporate feedback and suggestions and have impromptu meetings to, at staff suggestion or our suggestion, just to like, we have a problem solve anything that has come up during that day or that they see as being an ongoing trend that we need to address. PPE has been an ongoing source of stress for our staff. We are fortunate to be in a system that has provided us with droplet precaution PPE. There's been a lot of education that our team has needed to do to educate staff regarding droplet versus airborne. I think staff would feel best either being in a PAPR or an N95 all the time, and that's just not possible, nor is it recommended for droplet precautions. So we've really been working with our supply chain and our staff regarding ensuring that we have enough PPE. And actually just recently, starting April 1st, our facility has an extended masking option for staff who want to wear a mask throughout the day. I think one of the biggest challenges and support needed is to help manage our staff's anxiety. This is something for all of us where usually if there's a crazy day at work, we can go home and we have the shelter of our own home and our friends and family to receive that support and resilience, build our resiliency back up. But in this situation, this is 24/7. We're dealing with this at home. We're dealing with this at work. It's surreal to be going to work every day and seeing all of our friends staying at home and complaining about being bored and, you know, that sort of thing. So really spending a lot of time working with our staff to help manage anxiety around that. We've had infection control come and talk with us. We've been involved in meetings throughout the county on Zoom meetings with public health. And we are working on a staff town hall so that we can have any staff who are interested, regardless of whether they're on shift or not that day, to be able to meet together with one of our infection control docs and just kind of ask any sort of questions that they might want. We've had several of those type of meetings, but typically it's usually just staff that are on shift that can attend that, and we're a 24/7 facility, and there's staffing that are on a 2-week rotation. So we really want to be able to provide staff with that support. And again, frequent recognition and appreciation. There's been lots of treats and lots of cards of thanks and anything that we can do to recognize and appreciate our staff. Patient and staff testing. Again, patients are screened daily. We isolate and test. Like Leslie mentioned, we have 2 rooms that are set aside as isolation rooms currently, community room and 4 mattresses tucked away in case we ever need to use that. Starting today, we just got approval last night to be able to test every patient at Medical Respite regardless of symptoms. This is a big, huge step for us, and I think it's because access to testing is greatly increased and the incidence of COVID-19 is just skyrocketing in the homeless community, whereas the curve, we're on the downside of the curve for people who are housed, but for people in the homeless community, we're still going on the upside of that curve, and it's getting pretty frightening out there for everyone. So we're today taking 4 patients over to our employee and patient testing site every 20 minutes and trying to get our entire census. We have 33 patients here right now, trying to get everybody tested so we can at least have a baseline of where we are. Very recently in one of our homeless shelters, there were at least 11 positive patients, and the majority of them were asymptomatic. So we're just trying to get a baseline as to where we are in our community. From there, we're testing all patients upon admission, and then we'll continue to test if symptoms present. We have staff daily attestation. Staff come in and kind of pause and review any symptoms that they might be experiencing in their bodies. And if they're feeling like they're healthy, they sign an attestation that, yes, I don't have any of these new symptoms. If anybody does, typically what's happening now, people are actually really staying home. Instead of, I can get through and work. People are staying home, and then as need presents itself, there's testing available to all of our staff if they meet the criteria that makes us concerned for COVID-19. A little bit more about how we have been supporting Harborview Hall and development of this new COVID-19 shelter. So medical respite staff have been hosting staff that are going to be working, or that are working, it just opened yesterday, that are working at Harborview Hall. So they've come over to Respite and they've been working with our staff and shadowing them for a couple of days. And then our staff have also been going over to Harborview Hall to provide support and actual staffing there when needed. We've been working with them on helping to create protocols and providing infrastructure support. And the other piece of that is working with our own staff here at Medical Respite around usage of this shelter. This shelter isn't meant for, as soon as a respite patient tests positive, they go over to that shelter, because there's such minimal staffing there that we would not be able to meet the needs of our patients. So it's, again, addressing that concern with our staff around when patients do test positive, how we are caring for patients and staff in a safe way as possible. And then I just wanted to bring your attention to some resources. I might try to click on a couple of these websites to show you. This one is a great one. Can people see that? So this is a public UW Medicine COVID-19 resource site that provides lots of information that we update as frequently as we update our own information around testing criteria, sample collections, PPE recommendations, triage. There is a ton of information here that might be helpful to you. So I wanted to bring your attention to that resource. Let me see if I can get back in. Then I wanted to bring your attention to our local Healthcare for the Homeless Network resource. There's a ton of information here too, and I imagine your local public health departments also have similar guidelines, but it might be helpful. I think we might be a little further ahead as far as like information in multiple language for patients and that sort of thing. So this is a good resource for that. And then the last thing that our system has been using quite a bit are the COVID-19 health metrics that you can find right here. I'm waiting for it to load. Okay, I would like everybody to go ahead and load that. I'm remembering now that you need to be in Chrome to be able to access that, not Internet Explorer, and this is routing us to Internet Explorer. But what it does is it goes state by state, and it gives predictions. As long as we're social distancing through the end of May, it gives predictions for each state on the amount of usage, numbers of deaths, where we are in the peak, and what sort of protocols have been put in place for each state. So it's a really helpful resource to access.
Melissa, we can actually.
And then go ahead.
We can see it. It's pulled up.
Oh, you can? Okay, good. The last thing I just wanted to make you aware of is our, I think, can you see this? Our COVID-19 protocol.
Is it a document, Melissa?
Yeah, hold on for a second. I'm going to see if I can make it work. Okay, so this is our protocol that, again, is a work in progress. I can't tell you how many times we've changed this, depending on changes in recommendations and new things that come up that we continue to think about. So this is something that you have access to as well, and it just kind of goes step by step in showing what we're doing here at our respite program. Social distancing, symptomatic patient workflow, and everything that we're doing step by step to manage our swabbing, and then what happens if they're positive, and room and belongings management. Once patients are in ISO rooms and we do have patients that test positive, here is the protocol for how we're going to manage that. It really goes step by step and might help some of your programs at least be able to adjust or amend based on what sort of resources you have available, and depending on what sort of support your respite has. Supplies and medications, PPE, it kind of goes through every every possible thing we could think of. Am I back? I'm trying to not share my screen anymore. Thank you. I think that's all I have. So thank you so much. And I'd like to pass the baton to Donna.
Hey, thanks a lot. For full disclosure, I'm a UW grad. I'm not sure you knew that.
Hey, I didn't.
Bachelor's 2004, master's 2006. So a big UW connection here. And I have seen those UW resources. Matter of fact, I went directly to that site because I knew UW would be out there leading the way several weeks ago. So my name is Donna Biederman. I'm with the Durham Homeless Care Transitions Program. Durham Homeless Care Transitions, and I chose not to use slides today because I was afraid of the technology. But Durham Homeless Care Transitions is more of a grassroots medical respite program. We began in 2014 actually as a pilot program that was unfunded and really a grassroots effort. We received funding, philanthropic funding in 2016 and launched a full program. We're a scattered sites model. So when we receive referrals, we tend to put them in sober houses in the community, primarily sober houses because that's what we have access to. Occasionally, if patients cannot maintain sobriety but they want to interact with our program, we will put them in a hotel so they can interact or meet them where they are. We, in addition to medical respite, we do a lot of case management. So you're not, even if you're enrolled in our program, you might not be in medical respite. For instance, right now we have about 30 enrollees, and we have 4 people in medical respite right now. So medical respite for us is those patients that are too sick to be on the streets or in a shelter, but too well to be in the hospital setting. Because we are the city of medicine, or the city of health, we have so many healthcare resources. We do not provide on-site medical care for our clients. Actually, we bring them in. We provide the space. Home health can come in. Hospice can come in. Different service providers can come in. It's been interesting, COVID, and so far we have no COVID-19 positive homeless patients in our area that we're aware of. That said, and I think in North Carolina and many places, we're kind of going to the hotel or motel model, and I don't know, Julia, is that happening in a lot of places nationwide? Yeah, so with the hotel model, we have essentially what we're calling the well hotel and the isolation hotel. Interestingly, well, I'll go a different route. So how we began planning for this actually is there's an emergency operations command at the county level, and we'll just call them the EOC. So the EOC got together and started developing a plan for the county. Interestingly, there wasn't a representation from homeless services there. And so that was a first omission we noticed and really started pushing for that and got homeless services involved. The EOC is primarily operating at a government level, though actually there's no service providers, direct service providers or boots on the ground there. So we quickly said, hey, we need a medical respite committee. We'll form that to inform our EOC. And so that's how we've been informing and influencing decisions that are being made. Our medical respite group meets very frequently, practically daily now, and it includes a lot of hospital representation, hospital case management. Every time she gets the chance, the president of one of our local hospitals joins just to ensure that they have, that they're confident that they can safely discharge patients back to the community. Our testing is improving by the day. Right now, in-house, I'm affiliated with Duke University. Duke University Health System can process 500 to 600 what we're considering rapid tests a day, and that's 4 to 5 hours, just as you all said. We actually just received approval for a 15-minute test, and we can do 275 of those a day. And there was an application that went out this morning to providers that if you feel that you work with a priority population and you should have access to 15-minute testing, that you could apply to be in the pot for those 275 tests per day. We've got a group of 3 physicians that are working together to secure some of those tests, and we want to do on-site testing. So we're going to, we have access to a mobile clinic, and we would like to take the mobile clinic to our hotels rather than transporting patients that are potentially COVID positive to the hospital setting. A bit about the hotel setting. Our EOC determined there was a lot of pressure on us from the medical perspective to decompress the shelter population. There wasn't room for social distancing in the shelter population, and so the decision was made that the shelters would close. And so our shelters closed, our 2 emergency shelters, and a hotel was rented for 2 months, and it's open today. And so today our urban ministries, which houses 112 single individuals, and I'm not sure how many families, is moving to this hotel. Actually, urban ministries is moving all their staff there as well. The plan was hopefully before people got on the bus, they were being screened, symptom screened, and that's been happening daily there anyways at urban ministries. And then anybody that screens positive was going to be sent to the emergency department for testing. Our emergency department is equipped for that. They've got an outside testing station, so one of our emergency departments is equipped to handle kind of a surge in testing as long as they have a heads up. So we've been in constant contact with them. We've got our isolation hotel. It is opening today. And prior to the shelters being completely emptied about a week ago, all the most vulnerable patients to death, they got COVID. Now we're kind of like compiling these 2. Going to be moved over to the Urban Ministries Hotel today as well. So anyways, there's the Ball Hotel, there's the Isolation Hotel. We're developing protocols around day screening still at the hotel and what to do if any of those well folks screen in. We've got our respite protocol. It's hot off the press. I'm not ready for prime time sharing yet. And this is what we're sharing with our EOC, though, saying this is our recommendations. Right now, security is a continued issue in the hotel setting, and for a variety of reasons, trying to keep people from coming in, not necessarily people leaving. And so definitely recommending on-site security. But then once, as Leslie mentioned, you know, these are people that are not trained in trauma-informed care. Some of them do not have a history of working with this patient population. And so it's a very fine line. We're looking to try to make sure that the patient population or the homeless population isn't victimized by this experience. And I would say that is kind of where we are right now, geared up to provide care for the people in the isolation hotel. If any of our medical respite people in our scattered sites facilities end up with symptoms, we're doing telephonic case management now, and so we're checking in on them daily. If they screen positive, we will get them a ride to the emergency department. They will be tested, and then they would go to the isolation hotel if they were. I have to say, from an advocacy perspective, the hospital has been such a strong partner in this, and our relationship has grown so much, and it's been really great.
Well, thank you guys. I really appreciate those quick updates on what you guys are doing on the ground. We're going to move now into question and answer. So everybody who's attending, please feel free to use the chat box to ask questions or to answer any of these questions, and we'll share what information you're sharing if you have experiences or things that are working in your community that you want to share. The first question I have is just some clarification, Melissa, around you're saying that when folks are coming in, you have the screening rooms. So if somebody in your respite program does end up testing positive for COVID, are they staying in your respite program or are they transitioning to a different space?
They're staying in our respite program. So that's why we have 2 empty rooms right now, to be able to accommodate for that, with the potential of increasing that number. So if somebody tests positive, they will stay here at respite. For now, they would be alone in a room, and then we will, as needed, cohort positive people in the same room.
Okay, We've gotten a few questions about smoking and what the protocol is for clients who are smoking. I'm not sure if your space, if you have an already like fenced-in space for folks to go, or if they're having to leave and come back in, what the protocol is around hand sanitizer. So how are you handling smokers in your program?
Is this to me?
Yes, Melissa, sorry.
Or to
yeah.
Leslie? Okay. So we think that what we will be doing is, of course, encouraging folks to use nicotine gum and patches as much as possible. And Leslie's been working really hard on protocols for folks that might be going through some withdrawal. We may allow folks to, with staff escort and masking, go outside on occasion to have a smoke and then come back in. At this point, we haven't had anybody test positive, so everything is theoretical until it actually happens. Leslie, do you have more thoughts on that?
I would just say that there has been a lot of staff angst about the leeway that we give patients in many regards regarding drug use and behavior. We work really hard to keep patients in the program and engaged, and they have a lot of fears that we will do the same with the patients in isolation to the extent that it will really place our other patients and staff at risk. So we have worked to try to reassure them about that, and the county has indicated that they will potentially detain somebody that is not seen in isolation, and if we have somebody who really repeatedly is violating the recommended quarantine and not putting a mask on if they go out to smoke, we will notify the county and ask for assistance for that.
So Leslie, I'm glad that you brought up this conversation about this new space, I think it's the Harborview Hall, and these ideas of, it's not necessarily medical respite staff who are able to staff these COVID hotels or whatever folks are calling it, depending on their community. And a lot of times it's a volunteer force, or it's people coming from the Department of Health who often maybe have not worked with this population or don't operate out of a harm reduction model necessarily. I'm saying that generally. So I'm interested in this shadowing piece and whether or not the folks who have volunteered or who are coming in and working in these spaces have been open to that learning and that education. Has there been some pushback? Are they interested in learning this information and what Respite has to offer?
I would say they've been very receptive. They all are coming from, they're employees of Harborview Medical Center County Hospital, and the people who work in that facility are committed to the populations that we serve, so they're very open to it. And receptive to understanding trauma-informed care and how to manage substance use issues. And I think it is key for these COVID shelters to be able to be run on a less formal basis that might not require RNs or MDs. The only thing at our Harborview Hall site that requires an RN is if there is methadone that is delivered, that the RN accepts it with a witness present. And the RN would do the daily, open the lock bag that the patient holds on a daily basis to observe the patient taking the methadone, and all of that is witnessed with initials, just to keep everybody safe in terms of potential liability issues. Somebody brought up telehealth, and I'm interested to hear how that is going, how that transition is going, if clients are responding well to that, and if that is something that you think will continue potentially after we are through however long this COVID pandemic will last. I can speak to that because I work at Pioneer.
Okay.
I work at Pioneer Square Clinic. We are doing telehealth. We're doing telehealth with our patients, so I've been doing that with my patient population. For the most part, patients are relieved. I've had one patient say, absolutely not, I need to come see you in person, but patients are relieved that they don't have to come in. They're concerned about their own safety, and I feel like it's working quite well, and I could foresee this continuing for patients that have mobility impairment, live distantly, have transportation issues. That could be a positive ramification of this crazy, difficult situation.
You know, Julia, our mental health providers are offering telehealth in all of the hotels in the area. And so it's really interesting, though, last week on this very town hall meeting, I heard in Oregon there's a group that has a van, and they have a table in it and chairs, and they do a mobile telehealth. And so they'll go out to an area and set the telehealth up. They'll go back in the van, and then they can communicate that way. I thought it was a really interesting model and something that we may want to try.
Switching gears here and just thinking about folks in isolation, and what are some strategies for people who are bored? How are people staying occupied or busy when people get bored or antsy or uncomfortable? I think it's harder to comply. I think that's true for all of us, but I'm wondering how you guys are addressing that with some of your folks. And that's open.
Our rooms are pretty bare bones, so there's no TV, no phone. So what we've prepared for is we have DVD players and lots of DVDs that we can pass out to patients that are in isolation rooms. We've created 3 different cordless phones from the nursing clinic that can go into those rooms so that patients can communicate with us and with friends and family from their room without leaving the room. A lot of patients have their phone or something that they might be able to access, and there's Wi-Fi here, and we're hoping to get some donated iPads to be able to help support folks while they're in isolation.
And then what are you saying to folks who are really struggling or resisting the idea of isolation or social distancing?
You know, I know that.
How do you handle that?
You know, the health department order and that they can call the health department to enforce the quarantine order. We have not done that yet, just kind of waiting to see if it needs to be done. So far our health department, to my knowledge, has not issued any type of formal quarantine order.
Great. Can somebody speak a little bit more about treating substance use disorder while in isolation or quarantine, and the staff training that maybe needs to happen, especially if you have a skeleton crew, and some of the recommendations you might have for managing substance use disorder during this time?
Sounds like
I think Leslie should take this one away.
Not easy. I think being proactive about preparing your opioid treatment program to deliver to the COVID shelters is really important. And I hope that maybe our outline of protocols and forms might be helpful in that regard. Nancy Sugg developed most of the protocols for the Harborview Hall shelter, including Librium for patients going through methamphetamine withdrawal and pretty liberal use of Librium for alcohol withdrawal, and with the hope that patients won't have such significant cravings and withdrawal that they need to leave isolation. We also are lucky to have the support of the addiction medicine service at Harborview, and we are going to be, anybody that comes in that's opioid dependent who is not on methadone or Suboxone can be rapidly placed on Suboxone for the duration that they're in isolation.
We're currently working on our methadone right now. One thing, our mental health MCO, if a person is connected to them, they do have a peer support specialist for everyone going into a hotel. And so this will be chronic peer support, but still to have that peer support might be.
Let's talk a little bit about discharge. So for your current respite clients, Most of the time when people come into respite, there is a health plan or a care plan put into place. A discharge date is in mind. They meet their plan, and then they are moved out of respite. Knowing the vulnerability of folks right now and this sort of shelter in place, are you pausing discharges of the clients that you currently have in respite? So that's one question. And the second part is, when and how are you discharging folks who were COVID positive who have now tested negative, and where are they being discharged to? Or what's the plan if you haven't gotten to that point yet? That's open.
Recently, we have learned that we're not able to get any patients, very few patients, into shelter system right now. Either shelters are on lockdown or just are not willing to accept patients. We haven't got to the point yet of needing to extend discharges. I anticipate that happening as this continues to progress in the homeless community. We have started doing a tent and sleeping bag drive so that if worse comes to worse, we can give patients a warm option. Sometimes our patients don't want to discharge to a shelter anyway. We have one patient where we're getting a plane ticket for and sending them back home across the United States. As this progresses, I think that we do have 2 or 3 people right now that we are really nervous about that are super vulnerable. It would be a case-by-case basis as to whether we hold on to them during this time. I mean, what happens when we, at least in our community, if we keep people beyond their discharge days, it doesn't allow for other people who need us to be able to get the respite services they need. So we'd really have to think through that carefully.
A little different for us because that just means we pay rent for a little while longer. We tend to be able to find enough resources, housing resources in the community that we can rent. We have a housing specialist on our team, so we're actively looking for transitional housing or permanent supportive housing for our clients and have a pretty good track record of discharging into those situations.
I would say if we were discharging somebody who's COVID positive, we would either discharge to Harborview Hall or to one of the county isolation and quarantine sites. And if we weren't able to do that, we would probably hold on to them to make sure that they're safe and that it keeps the community safe.
Yeah.
And isolation hotel, we're following our hospital guidelines for discharge of COVID positive patients.
Which, Donna, can you say briefly what those guidelines are?
Same as yours, Leslie, and Melissa. I'm thinking it's either, is it 12 days from onset of symptoms plus 3 days fever-free?
It's whichever one is longer. Yeah, it's whichever one is longer. I thought I should also mention that in the protocols for Harborview Hall, we have just a bare bones, maybe 7-10 point list of indications for transferring a patient to the emergency department that the nighttime EMTs and MAs can follow.
Great.
Yeah,
Melissa stepped away, but Leslie, you might be able to talk about this. In terms of these isolation rooms or spaces that are being set up in respite for people to come in who maybe are pending, tell us a little bit about the decision making to house multiple people potentially in one room who are pending. Is that resource related? I don't know if there are any guidelines around that. And then also when somebody is moving out of that space, are there specific protocols that you're using for cleaning that space or turning that space over? Is there a certain amount of time that you wait in between bringing folks into that pending space?
Yes, so we have set it up so we never have a test pending patient roomed with a known positive patient, but we have followed the format that our county hospital ED is using, in which they have a COVID lounge where test pending patients are hanging out. So that's what we've been doing. Sorry, I'm trying to remember the second part of your question. What was that?
So what's the practice for, I guess, cleaning that room when folks leave? Mm-hmm.
Yeah, so if we have, for example, a 3-person room and 1 person turns positive, I would say in between our beds we have curtains, and the beds are 6 feet apart in the room. But if somebody in the room is being tested, for example, they would be moved into a space pending the test result. That all of the belongings of the roommates would be cleaned. The entire room would be terminally cleaned. The other patients moved out. And so, yeah, it takes quite a bit of environmental service support, and we have the luxury of being able to call upon the hospital when we're doing that. But we've really had to beef up the frequency of our cleaning and have a process in place to rapidly get a room cleaned if it's known to have been exposed.
Great. Okay. Thank you. This is a HIPAA question. Get excited. Are there any HIPAA or privacy considerations for communicating test results to non-medical staff who are working in the isolation sites? Do you know how they're managing that?
We're using a universal consent, and so as the hospital is charging a patient, the patient's being asked to sign a universal consent, or we can have 2 nurses co-sign that and do it verbally. And universal consent has a list of all service providers that are involved, and the person needs to initial it. Right now, the only legal hurdle that has not cleared is the end date. So right now it's just open, and the hospital's saying, like, no, this is not open. This needs to be time limited. So how long will we share your information with these other organizations?
Great. Okay. One more quick question. This is going back to I think the role, what we're learning a lot about respite in response to COVID is that I think, Leslie, you described it as a responsibility of respite programs to really try to reach out to other folks who are going to be staffing these spaces where people who are experiencing homelessness are going to be. And outside of shadowing, what are some trainings that you specifically recommend that respite programs recommend or facilitate for people who are working in these COVID positive spaces, or even just isolation spaces?
Well, I would say on a little bit separate note, I think that if it appears in your community that the response is not really proactively addressing management of substance use disorders, I think initiating that conversation, assisting in that process is critical. And I think it's difficult to rapidly train staff in trauma-informed care and harm reduction practices. And so I think our contribution to allowing staff to shadow our staff has been very successful.
Julia, kind of along those lines, we're developing a training that we're going to hold locally next Wednesday. And it'll be my nurse practitioner colleague, who's our program director, and myself, and a public health nurse, on how staff that are in other congregate settings can stay safe and protect their patients to the best of their abilities. So that's in the works here.
Is that going to be a webinar?
I don't know. I think it's probably going to be Zoom, but I could definitely do a Zoom recording of it.
That would be fantastic. If you are able to record it and interested in sharing it with us, we would happily take that.
I would also just add that any sort of de-escalation training and milieu management type work would be really important.
Okay, great. That's really helpful. We only have a few minutes left, and I have a few resources that I want to call out before we end today. So if we didn't get to your question, I'm going to pull all these questions and go through them and send them to our presenters, and we'll get a written response to these and send them out to the full group. So if we didn't get to your question, sorry about that. If you still have a question, though, please put it in the chat box, and we'll make sure we do get to it. Yeah, I just want to take a few minutes to highlight some resources, some current resources, and then some upcoming. So the Council has been working tirelessly over the last few weeks to get resources out to the field. And I want to highlight a couple of them, a few issue briefs that have been done, one on needed policy responses for high-risk groups and needed actions for public health and emergency response systems, and then COVID-19 and diabetes. All of these resources are on the Council's COVID-19 page. It's actually the coronavirus page. So, and these resources and a ton more, including a lot of local guidances that people have shared with us. And speaking to that, we are really wanting to collect documents and resources that you are using on the ground. As I said earlier, response to COVID seems to be very community specific. So if you have something that you're willing to share with us, please send it to my colleague Michael Durham, and we'll put it on our website so that everybody has access to these resources and people can see what other communities are doing, so nobody has to reinvent the wheel. Yeah, again, I highly encourage you to go to our website and check out those resources. A few things coming up that I want to call out. So my colleague Regina Reed is working on an FAQ regarding the funds from the CARES Act that Congress recently passed. $4 billion have been allocated to ESG funds, Emergency Solutions Grants, which is going to come through HUD. And so this FAQ will help folks, direct folks into how to access those dollars for healthcare services. Another thing, and this has come up a few times in our conversation today, my colleague Catherine Cavanaugh, who works with our National Consumer Advisory Board, is putting together a paper on reducing harm during the COVID-19 pandemic for people using drugs, alcohol, or substances. So that's really a harm reduction paper that I think is going to be really useful for a lot of our providers. Those two should be out sometime next week, so keep an eye out for those. And then additionally, our Clinicians Network and the VA are partnering to work on clinical guidance for isolation and quarantine. So that should be coming in the next 2 weeks. Finally, I just want to call out that our town hall next week is going to be focused on mental health and quarantine. So again, we're having a lot of anxiety and concerns for our folks who are in isolation right now or quarantine and separated from their communities. So this town hall is really going to focus on how providers can integrate mental health care for our clients who are in isolation right now. Thank you guys so much for joining us. I really want to thank my presenters. I really appreciate you. I'm going to send you a ham. Thanks for being here. And thank you everybody else for joining us. I know it's a busy time. We appreciate you being here. There will be an evaluation that will pop up when you exit the webinar. Please take a moment and share your feedback. Also, the recording of this webinar will be available on our website next week, and the slides will also be made available. So thank you again, everybody. Please take good care of yourselves, take care of each other, and we will see you soon. Thank you.